So everybody, welcome, very welcome, and it is our pleasure and indeed our honor to be able to have the opportunity to coming back to you for session number 4. There's 2 more that we're going to get into, and hopefully you're noticing a bit of a pattern with respect to what it is that we're hoping to engage with you all around. We started off with a conversation really around equity and how we might think about being trauma informed and the importance of those particular issues on behalf of our communities and what's necessary when we're considering communities that we may not be able to reach out to very often. We then really had a wonderful conversation about looking upstream and thinking about different ways of bringing and employing strategies to address the opioid crisis and what are the tools that prevention leaders need to really understand and avail themselves of so that they might be able to place their communities in best position to be able to impact those conditions and situations that they find in their communities. And if they're going to do that, they need to do so with understanding a really having a strong emphasis on employing an environmental approach and doing so. And so last week, we had the great privilege of having a conversation with you about an environmental approach and employing prevention strategies that would affect the entirety of our populations. Well, today we're going to take that conversation and we're going to dig down deeper into a skill set that I believe is absolutely essential for prevention leaders to master if we're going to do this effectively. And so the title here is Media and Literacy, and it sounds broad, but we're really talking about best practices that are necessary for prevention leaders to employ if you are actually going to engage the community with respect to this. And so I'm really grateful to be here. My name is Carlton Hall, as most of you, I'm sure, know. We've been together for the last 3 sessions, and I am grateful to have my partner in this endeavor, Mr. Dave Clausen of DJC Solutions, to be with us as well. And Dave, if you wouldn't mind, just to make sure that we're all kind of doing this together. And I know folks, some of you have heard this repeatedly, so we're going to do an abbreviated version, but just to make sure, and just in case there are some new folks, if you wouldn't mind, go ahead and take us through a little bit of what we might need today.
Yes, indeed. So we've been in the Zoom world for well over a year and a half now, so you get a 30-second Zoom tour. That bottom left-hand corner, you've got the mute, unmute button. Feel free to use that. We would like you to stay on mute for the majority of this session. However, we do have the video controls there. We do love seeing those smiling faces. Across the bottom, you've got your participants, chat box, and cues where you can give us thumbs up, thumbs down, little celebration, round of applause. Use those reactions as much or as little as you would like. Towards the top right of your corner screen, you'll see speaker view. That's where you can change between speaker view and gallery view and change the layout on your screen, meaning how big the slides are and how many of the little cameras you can see. And if you have any technical difficulties, I will be hanging out in the chat box. And just a reminder, it's okay to talk during class. That's what the chat box is for. Right. We'll see you there. And there's your tour, Carlton.
Thanks so much, Dave. Appreciate that. So as always, really appreciative of the leadership there in your state who cares enough to ensure that we were able to have this conversation and this opportunity to kind of get together about how we all might be able to do our jobs more effectively. And so to the wonderful leadership at the Louisiana Department of Health and Behavioral Health, and our great friends at the Louisiana Center for Prevention Resources there at Southern University. Thank you. And I'm going to ask my dear friend Paula, if you wouldn't mind just to provide a bit of a welcome for folks and anything else that you'd like to offer at this point.
Good morning. Thank you guys for joining us this morning. Thank you, Carlton and Dave and Ivan. I appreciate the collaboration that the Louisiana Center for Prevention Resources and your team is having. We are providing this training to all our prevention specialists throughout the state. Today is Friday. Thank you for take your time and joining us this beautiful morning. And we're gonna do this. It's very interesting. We've been talking about media and social media. So this is going to be a continuation of a trainings on social media and prevention that we've been offering. I would like you guys to visit the website. Is the May calendar is already updated. About CEUs, I always remind you when you fill out your applications, make sure that you include your ADRA numbers if you want your CEUs. For other prevention, for other professionals that are not prevention, like social workers, we can offer the same opportunity through Southern University CEUs. So if you have any questions, please email me. I will explain all that works. And the floor is yours, Carlton.
Thanks, Paula. And thank you and everyone for the leadership that you are providing for this. As always, folks, I want to just make sure as we are offering our thanks, we are also sharing that we are indeed recording this so that you all will have access to it later. And as such, I wanted to also express that the views that we will be providing, both myself and Mr. Juzang, who will be joining us in just a moment, don't necessarily are supposed to represent the views, policies, and positions of the Substance Abuse and Mental Health Services Administration. And therefore, we can now really speak a lot about what it is that we're going to do today. It is my pleasure to be able to have with me a friend and a person that is also a partner with us in a number of endeavors. And I am bringing him and his voice and his research to bear for your use because I think it is just that critical. Even though we are and have been friends for a good number of years, he is deserving of a official kind of introduction. And so I just want to introduce Ivan Juzang. Ivan is the founder and president of Me Productions, which is a market research, health communication, and social marketing firm that specializes in culturally relevant behavior health messages for hard to reach, low income, and underserved audiences. He has a number of degrees, some degrees from Carnegie Mellon University, and he created Me Productions during his final year at the Wharton Graduate School there at the University of Pennsylvania. They've gained some national prominence for some of their primary research, a primary research study entitled the Me Report, Reaching Out to the Hip Hop Generation. And over the years, Ivan and his team has helped mental and public health agencies engage low-income communities and youth affected by many of the desperate issues that we are all here to speak to and talk about. He is an extraordinary leader, but let me share with you why I think this conversation is so vitally important. We've had a number of conversations, and very often I feel as though those of us who have been working in prevention far more often than I would like to see show up sort of like preachers who care more about the text of what it is that they're going to say than they do about the congregation and really understanding the congregation and the needs of the congregation as they're engaging. And I use that analogy because we have become really adept at understanding the importance of our prevention science tools and techniques, particularly the public health approach that we embrace towards prevention. As you see here, there are a number of steps that we have been engaged with. In fact, the last 3 trainings that we have had together have focused on these steps, right? Defining the problem, looking and identifying those risk and protective factors, and developing comprehensive sets of strategies. So understanding the relationship between agent and host and the environment, and how we might employ comprehensive strategies to address that. But as we understand, the public health model has a final step, which is to ensure that widespread adoption is occurring within our communities. If we're going to be impactful in the work that we are doing, we have to find ways in which we are able to engage the broader community in the prevention science efforts that we are trying to employ, that we know is so desperately needed in our communities. That's our next step. That's the next role that I believe that prevention leaders need to and ought to focus on. And so today's conversation is really around what I refer to as the science of communication. And communication is really about the science of connecting with relevance. How do we take this prevention science and connect it with relevance to the communities that we are serving, and many of them harder to reach communities? And so with that bit of setup, I'm wanting to have my good friend Ivan Juzang to come forward and share with you some information that he's been doing around the country. He's going to share a little bit about his organization, and in the midst of that, share with you some of the impacts that he's had, even in your state, I would imagine, and share how the tools and the science of communication are an important effort and need and focus for us as prevention leaders. And with that, Ivan, thank you so much, and take us forward, my friend. Looking forward to the conversation.
Thank you. Thanks, Carlton. Thanks, Paula and Dave. So listen, let me share my screen and we'll jump right into it, because I know we don't have all day to do this. So let me go back to the top here. So here we are. Really happy to be here. You guys will see in a few minutes the work that been doing in Louisiana actually for the last 8 years. So I'm sure there's a lot of kind of cross connections. I really wish I was there in person. I miss my normal quarterly trips to Louisiana. I've been all over the state, from Shreveport all through the middle, all the way down, obviously, to New Orleans. So my families are migrated from New Orleans to Mobile. So I have a lot of roots there in Louisiana. Louisiana is an interesting state, as you guys know, and I'll talk about some of the challenges that we've tried to address and work with, and I think there's a lot of overlap, hopefully, with what you guys are doing. I want to start off by giving you just a few quick messages. What we're going to talk about today are strategies that I just want you to, as Carlton said, how do we get to widespread adoption? These are strategies that are culturally relevant. You'll see over time that they're actually the most cost effective. They actually, and this is because I've been doing communications media for the last 30 years. They're actually the most cost effective. So you can actually have something that's most culturally relevant and the most cost effective at the same time. On top of that, you get the benefit of upstream primary prevention. We'll talk about why this is critical, because we're dealing with health disparities. And I know you guys are focusing particularly at substance misuse, but there's a number of disparities that these communities are dealing with beyond just substance misuse. So we'll talk about how primary prevention helps not only your issue, but other issues as well. And the last thing, it's strength-based. over the years, I've learned, don't go into communities talking about their deficits. You have to understand that they're in the worst communities, there's strengths that are there that you can be tapping into. So I want to leave you guys with that as we get started. So as Carlton said, my company is a behavioral health communications firm. So we look at behavioral health from the perspective of consumer market. I always tell folks there's consumer marketing, there's behavioral health marketing, social marketing. And it's a big difference. Consumer marketing is, am I going to buy Pepsi or Sprite? Behavioral health communications is, am I going to use a condom or not use a condom? It's a different value proposition. It's a harder sell. So I want you guys to understand you're actually doing a harder sell, but it's doable. And we're going to talk today about how to do it. So we've been focusing on a number of disparities for a long time. So I just want to kind of have you guys see this. So this is, again, health disparities is kind of, the term finally has come into, I guess, into favor or vogue because of what's happening with the pandemic. But I've been dealing with health disparities, particularly around HIV, substance abuse, youth violence, again, for the last 30 years, and then a number of other ones. So around substance abuse, you guys, my first project was funded by the Robert Johnson Foundation called Reaching the Hip Hop Generation. And, it was very controversial because we were the first, it was the first national research to challenge the Partnership for Drug-Free America ads on This Is Your Brain on Drugs. And what our research found in low income communities that not only were the PSAs not effective, they were actually counterproductive and insulting. So when people think they understand media and literacy, this was an organization at the time that was getting $10 million a year, and they didn't know the impact of their ads on the communities that they were trying to target. So that's the first thing. Then that moved into, I know some of maybe the old folks on the call like me and Carlton may know Linda Bass from CSAP. So then we started working with CSAP, and we put out a major study called Elevated the Blunt Truth. And then that was really where we started focusing a lot on, underage marijuana use. And then that led to me sitting on the National Drug Control Policies Board for about, I don't know, almost 10 years, then working in tobacco in California. And you'll see me talk about the work I'm doing in tobacco in Louisiana with LPHI there, underage drinking, and then obviously a lot over the last 5 years around opioids. So we'll get into all of that, but extensive, not only interventions, but also research as well that we'll share. So here are the audiences, a number of various audiences. All these audiences, mostly the top ones, have health disparities, right? So again, based on who we work with, we understand that there's disparities in a number of communities, and particularly our work in white rural America and Black rural America shows extensive health disparities as well. And I'm sure you guys are working in some rural communities, and we've been doing a lot of work in rural communities in Louisiana, so we'll be able to talk about that as well. So I just want you guys to know, it's not my first rodeo with the state of Louisiana. Again, since the early 90s, I've been working there, particularly around HIV. We've done a lot around Black youth sexuality. We've actually implemented a campaign in Louisiana around ex-offenders' voting rights in terms of looking at reenfranchisement. Done work was there right after Katrina. Again, been doing a lot of work, did some national research for My Brother's Keepers initiative, which is President Obama's foundation looking at issues with boys and men of color. So a lot of work in Louisiana over the years, besides other places around the country. I was just kind of showing you some of the main areas we work in. Here's our recent work in Louisiana, just so you guys know. We've been working with Bureau of Family Health at the State Department, and we work with Earl Benjamin. We work with a number of leaders there. We also work a lot with LPHI around their tobacco quit line. So we actually run the campaign for LPHI on tobacco cessation campaign, particularly targeting African-American men. So just a number of different projects throughout Louisiana, including some kind of strategic consulting work for the city of New Orleans opioid prevention campaign. We didn't actually implement it, but we were involved early on in in the research design for that. Focusing a lot now, you guys, on kind of systemic inequities around tobacco use amongst African-American men in the South, particularly in Louisiana. So just so you guys know that. So here's what I want to I always say, what are some of the learnings I want you to take away today? As we get into the detail, you'll hear me kind of come back to these themes. First, the number one thing in health communications is you have to go into communities understanding that the reality is that these communities are not making bad choices. That's what the media tells you. The media only shows you risk factors. So you have to understand that these communities aren't making bad choices. They're making uninformed choices. Big difference, right? If you don't have certain information to change your behavior, you only can follow the behaviors that have been modeled for you. So when we look at a lot of the negative coping, we have to understand that a lot of this is uninformed choice, these are what they always say around, what I always say around behavioral health. Certain things that have been learned can be unlearned, and we have to understand that. Next thing I want you to understand is that a lot of our communications, when we talk about best practices, the number one thing we hear from our communities is that you're not talking to me. You may think you're talking to me, but you're not talking to me. And what we need to understand is that you're not speaking to how they view the world. A lot of times when we go and do communications, we focus on how we view that audience versus how they view us and view the world. So you got to make a big switch there. And what we see with the first two is that because we don't understand what's happening in communities, they opt out of our communications. And then if you look at communications, most of it has been particularly around substance abuse. It's been punitive, it's been preachy, and it's been deficit driven, right? So if you look at that, we should wonder why our prevention efforts aren't effective, is because we're going into these communities actually insulting them from the get-go. The next thing I want you to understand is trust. There's some major trust issues when you go into communities that have health disparities. And it just makes sense. If you have health disparities, you probably have trust issues. Why? Because it's how you've been treated by the systems. So we have to understand that we are going to have to address trust issues. So we're going to talk about who therefore is going to be the best sender of the message. And we need to understand that if we're trying to drive folks to services and treatment, and we're trying to prevent stuff, we have to understand what's going to happen when they get there. And so we don't look at the treatment at the location level. So we're going to talk about health communications today. This is really behavioral health communications 101. Communications, I know you guys may or may not have the slides. You'll have access to them, obviously. But if you just have one piece of paper, landscape, and you just write big letters on it, SMCR, sender, message, channel, receiver. You don't have to write that out. Just write in SMCR, and you'll be able to take all your notes from the workshop on one piece of paper, because I'll show you how to use that just one piece of paper to take key notes. So we'll talk about the health communications model, how we flipped it. And then we're going to talk about really one of the things that I've learned is primary prevention is protective factors. And we'll talk about that. We have to start saying protective factors. We have to say resiliency. We have to say healing. We have to start saying some different words around what primary prevention really is for our communities, but it's resiliency. It's getting up from a setback and keeping on, right? And I do want you to know that primary prevention is doable. And as we're seeing today, you guys, it's more important than ever. I mean, health disparities have been exposed finally on a level that I think people are understanding. And so we're gonna go into that. So that's what we're gonna do. Looking forward to the conversation. I'm gonna try to get through this real quick, you guys, so we can have a conversation and do Q&A. So as David said, keep your answers, keep them there. Maybe type them in when you have them, but you may have to type them in again, because as you know, with the chat, sometimes we lose them. So here's the flow real quick. We're gonna go through really this sender, message, channel, receiver model at the end of the day. So this whole slide is just saying that's what we're gonna go through, behavioral health communications. At the end, I'm gonna share some resources, research, publications, videos that will be available to you. All this you can get going through our training portal at metrainingportal.com/keynote. You'll have access to all of these resources, including the slides, unless Carlton and Paula get them to you directly, which is fine as well. It's a backup way to get access to everything that we'll talk about today, okay? So that's the flow, you guys. Let's get going into this. So I appreciate, Carlton, that introduction. People, need to understand the strategic prevention framework. I know you guys do. I know you guys talk about this. But what I want you to understand, as I said earlier, is what is social marketing. So what we're trying to do is get folks, we're using really some of the tactics of communications and marketing, but we're trying to get folks to change their behavior. Now, just so you guys know, you can't change anyone's behavior, obviously, but you have to give them the information to be able to change their own behavior. And so we use DiClementi's model behavior change. You know what I mean? So we look at pre-contemplation, contemplation, preparation, action, maintenance, relapse. So we understand all that. We're trying to figure out how do we help folks change their behavior. That's what we're trying to do. And we're trying to also not only help them change their behavior to prevent overdose, but we're also trying to help change their behavior so that they can address and deal with other health disparities that they may be dealing with in their life. So that's the strategic prevention framework. Again, I mentioned this. So on the left is the work we're doing with Quit With USA, Quit With Us, Louisiana. That's the campaign we're doing here. And then on the right is some of the opioid work we've been doing in Ohio, Pennsylvania, and Baltimore. So we'll talk about some of our opioid work as well. All right. So, so you guys, as I mentioned, this is our model for behavior change. So one of the things we always say when we're going into communities to do, as Carlton said, widespread adoption, is you have to know what you're trying to do. What is what we call your behavior health outcome? So we have a very simple model that you can follow, and this is applicable immediately. You'll be able to use this and share this immediately so that you can get going on your work. So what we always say is we're trying to move, in general terms, we're trying to move communities that live in stress and trauma to communities where they're thriving. And so we're not going to be able to change their social determinants of health, but we're trying to change how they address and deal and cope with their social determinants of health. So we're trying to get folks to go from unhealthy behaviors to making healthy, informed choices. That's always what we do. We say, how do we get folks to make informed choices, right? So we use this model called sender, message, channel, receiver. Any college uses this model. This is the basic model of communication. There's always the sender of the message. There's the message he or she's trying to send. There's the channel we're using to deliver that message. And then there's the receiver. And so this is the model that most people think about when they think about communications. And the traditional way, as I just mentioned, is left to right. But Me Productions, from a behavior health communications perspective, we flipped it. So we go right to left. And so we'll talk about that. This is the one thing you want to write down on that piece of paper, SMCR, and really we're going to go from there. So basically, you guys, what we're saying is that you always need to start with whoever your target audience, target community population is. You have to start with the receiver of the message, all right? And so then people go, well, okay, that makes sense. That may be cool. So if you're working with the highest health disparities, this is critical because they already don't trust us. So we have to understand that we have to start with them. So we start with the receiver. And then besides me just saying right to left, think about it if you want to, in the chat, just enter in, why do you think we should start with the receiver? I'm kind of curious to see what people say. Why do you think we should start with the receiver of the message versus the traditional way? And then go again right to left. So then if we start with the receiver first, besides just Ivan Juzang saying go right to left, why should we go to the channel second? So if you can, enter your thoughts about, we start with the receiver, why should we do that? But then why should we go to the channel next? And then why should we go to the message after the channel? And then why sender of the message? So this is what we're going to kind of go through today. This is really the workshop, and I'm going to take you through this so that you can start understanding what you're doing when you're going in to communicate with low-income communities that have the highest health disparities and mistrust us. All right. So we're going to look at that. So again, if you can give that some thoughts. So here's my quick 2 minutes. Receiver, we always start with the receiver first. Why? Because we need to understand, as I said earlier, how they view the world. I have to talk to their worldview. If I'm talking to my worldview, they're going to opt out. So I need to understand how the receiver views the world. Second reason why we start with the receiver is that we have to understand their communication style. We need to understand that, and I know the leaders on this call know this. What happens when in public health, we want to get funding for something? We write a great proposal, it has evaluation, it has reporting, and I always tell folks we're speaking to a literate-based culture. When we go into communities, if you can jot this down, they're oral-based. They come from the oral tradition. They could care less what Ivan Juzang has published. They could care less about our research. They want to know if you're oral based. So those are the two things we need to understand about the receiver. Then when we look at the channel, we need to know what's the best channel to reach that receiver. And the reason why we do that second is because the receiver will tell us what's going to be the most effective channel or credible channel to help them through the behavior change process. Then we can figure out what's the best message for that channel. And I can tell you, when I do radio ads, they're totally different than what I would do with a transit ad or with social media. So I have to know what those channels are, and then what's the best, and then how to create the best message for that channel. And then finally, who's the best sender of the message? And I'm going to let you guys know something. As an African-American, I don't go into the Black community and think I have credibility. I go through the gatekeepers. I identify who is the most credible sender of the message that's going to help me do behavior change. So we'll talk about this a little bit more, and we're going to go through each of these buckets now. So we're going to go through receiver, channel, message, sender. You're going to be like, wow, we're going right to left. Yeah, we're really going right to left. So get ready. And again, what I always say, it's not only what you say, it's how you say it. This is going to help you determine not only what to say, but how to deliver that message. And so this is going to help us counter lack of trust, help us reduce risky behaviors, and really, it's more than gaining respect. It's developing a relationship, an ongoing working relationship with the community. That's what we're going to focus on today. Okay, so remember, we're starting with the receiver. So we do a lot around how the receiver views the world. We do this so that we can develop messages on that level. So we try to understand how the community interacts with their world around them. So we kind of track these institutions that they have to deal with, everything that enables them to get employment, what's happening in terms of their relationship with government, what do schools look like from their perspective, what do human services look like, what does healthcare look like, and then how does the media portray them? So we always manage this. We constantly monitor how our communities that we're working in view the world, because we have to talk to that worldview, right? And so what I want you to understand is, we always say, now again, people are understanding social determinants of health. Just so you guys know, I refer to them as the social determinants of health disparities, because in many ways, we think that they should be assets. That's why we say the social determinants of health. But again, for many of these communities, they're deficits and their liabilities. So we would think that these institutions should be providing a service. And I hate to say this, in many cases, you guys, they're actually creating trauma. Or secondary trauma. So we have to understand that. So we have to understand this, and we also have to understand the worldview, because this is what drives mistrust. So the more we understand it, we can understand why. So I'm gonna give you some examples from our research, all right? So again, as I mentioned, we track these 8 variables, whether we're in urban areas or if we're in rural areas. And I'm just listing them real quick, because we track them so we can best understand how our audiences view the world. So we look at how they navigate the streets. So what's happening at the street level, i.e. violence, right? We look at how they view education. As I mentioned, economics, jobs, housing is a major economic component in these communities, as you know. Healthcare, public health, government, how they view. Carlton, I don't know if I've ever told you this, but sometimes when we're doing campaigns, I tell the client, we may not want to go into the community and say we're here from the government. That may not be the best framing of the message. So we understand how government is viewed, mass media, family, community, and mainstream. So I'm gonna give you guys a little data that I do have from Louisiana. I know in certain parts of New Orleans, there's a higher probability that young people nowadays will die between 14 and 24 than there was for my father who served in Vietnam. If you look at CDC morbidity and mortality data, that's how violent some of these communities are. And they're not just in New Orleans. You can go up and down the state where we look at why young people are struggling. And sometimes I'm starting to realize violence is a call for help. Not condoning it, not making an excuse for it, but something's happening where they have to react this way. And so we have to understand the streets. Education, I'll just tell you this real quick. We've done extensive research on education around the country. Real quickly, when I talk to low-income kids, Black, white, and other, long as they're low income, they can identify 3 types of teachers. Teachers genuinely concerned about them, teachers there just for a paycheck, and then teachers afraid of them. How are you going to teach someone if you're afraid of them? So we understand, like, we think young people are dropping out of school, and that's what the media shows us, dropout rates. What you need to understand from the community's perspective is schools aren't engaging. So they're not keeping them engaged in the process because of how we treat these communities. Economics, I'll jump through this one. Just a perfect quote that I've been using ever since I heard a young person say this when we were doing youth violence work. When you live in poverty, poverty makes you angry. And I'm telling you, but people don't know, I travel around the world. Poverty in America is different than any other place in the world. And people say, oh no, even the poorest people make more money than they do in South Africa, but you don't have media showing it to you every day, selling you consume, consume, consume. You can go to other countries and people actually live economically lower, but their mental wellness and their balance is much higher. They don't even know they live in poverty. They just live with their family, they go about their lives. So understanding poverty, healthcare. I'm gonna just say this one time because I've done research, including in Louisiana. Poor people have access to healthcare. That's the big notion. I've done this work for CDC for years. Do poor people really have access is the question. They have access. The reason why many don't access services is how they're treated when they get there. It's a treatment issue, not an access issue, primarily. You got to understand that. Government, I know you guys know this in Louisiana. I don't know if you know this, Carlton, you probably do. Louisiana right now in 2021 locks up more Black people than South Africa did at the height of apartheid. 4 times the amount right now. So again, we need to understand that many communities don't have the kind of relationship we think they should have with an institution that they pay taxes to. So we have to understand that they view the government differently. So I can go through all of these, you guys, so we can share the data with you, but understanding this stuff is important. And then finally, the last one here is mainstream dominant society, systemic racism. You have to understand this. I tell you, I try to break this down for people, but I think ABC News did a study a number of years ago that I always reference. They did a story on systemic racism. And this was 10 years ago, guys, way before a lot of the stuff we're happening now. Even though, again, we know it's been happening forever. The key thing you need to understand is that ABC did a study. It took a group of Black kids and white kids that had access to a suburban mall. So inner city kids could get to this suburban mall because it was close by. And of course, white kids in the suburban had immediate access to it. They did a few exercises. They gave all the kids $1 and said, go amongst the local merchants and get change. Black kids and white kids, right? All the white kids got change. All the Black kids were denied. You're like, this just is change, you guys. So next exercise, they gave all the kids a purse and said, go amongst the local merchants and return the purse. All the white kids returned the purse and were thanked, congratulated, appreciated. All the Black kids were in question, were questioned, held, and detained for security because they thought they stole the purse. They automatically thought they stole the purse when they were returning the purse. My point is just to understand that that's what actually happened in the moment, but it's an example of systemic racism because we'll say to these exact same kids, go amongst the local merchants and get a job. You see what I'm saying? So now, and again, this is not ABC, but another study shows what happens when kids go ask for a job. All the Black kids go and say, no, don't have a job, just don't have any openings. And it was interesting, white kids would come right behind them and they would say, you know, this is your lucky day. We just have an opening for a job. My point is the impact on young people is what? Just like we were all raised, you put your hand on the stove, how many times, you guys? Once, twice, and you stop going. You stop doing it. Same thing with young people. Racism beats down your perseverance. It beats down your ability to think that things are fair. And so it creates what I call normative behaviors around how you're going to be treated. And this all drives mistrust. So I just want you guys to understand that it's important to have a worldview. I'm not going to keep going into this, but I always say to folks that what we need to understand is failure is built in for many communities. It really is built in. And so you have to understand the challenges facing poor people of color. And this is an example of our work, just particularly with Black youth, with a campaign we're doing around youth violence in Philadelphia. So I'm just trying to give you guys a sense that we have to understand the worldview. We have to understand how our audiences that we're trying to change your behavior around view the world. So let's keep moving. So I always tell people the last part of this, how does those social determinants show up? They show up in negative coping. So when you live in a community like this, right, this is how you're going to cope with that community. You're going to start self-medicating, right? And not just with the normal things. I'm telling you, the major issue, and I know you guys know this in Louisiana, there's also addiction to sugar, salt, fried food, processed foods. A lot of times that's all they have access to because it's cheap. But this is also you're self-medicating with comfort foods, right? And then of course we see acting out. I put the line between the three at the top and the two at the bottom because the top three are more how we externally cope. The bottom two are another ways that we cope. We internalize. So we shut down. And this is what I'm convinced is driving chronic diseases in the Black communities, because we're internalizing that stress and trauma. And so this is why we're seeing people dying much earlier than we would think. So that's really what I want y'all to understand. So that's the first part. So sender, message, channel, receiver. Under receiver, the first bullet you need to write after all of that is bullet number 1 is understanding worldview. It's not how you view the world, it's how they view the world, the audiences you're trying to reach. Second point we're going to talk about is communications culture. These are the 2 bullets under receiver. So what I want you to understand is that the receiver has a different communication style than we do. So again, what I want y'all to understand is that in the world, there's 2 main communications cultures. There's literate-based culture, there's oral-based culture. All right. The way you can determine what people's normal communications culture is primarily how their family passes down their history. So many Europeans, they pass down their history through the written word. And then many people of color, African Americans, Native Americans, many folks in the Latino community, depending on if they're indigenous or not. We know a lot of Asian communities pass down their history through storytelling, through the narrative, right? And people always say, oh, well, that can't be too complex. It's very complex. Think about stories that get passed down from generation to generation without being written down, but keep the nuances and the details intact. So there's a whole process that has to go so that your grandmother may have told you a story that now you as a grandmother tell your grandchildren. That's the oral tradition. So we're going to go through that a little bit. But the key thing I want you to understand is under this one, I need you just to write 3 things. There's 3 things you need to understand about the oral tradition. First rule is that in the oral tradition, because stories are passed down through this storytelling, is if you think about storytelling, you have the right. The first rule is you have the right to challenge the sender of the message. So I need y'all to understand that is if we're doing substance abuse work and we're trying to go into communities, they have the right to challenge us. We're the senders of the message. We need to know we're going to be challenged. Now that's a tough one for people who come from a literate-based culture because they're the experts. They've written down, they've been published. So we know what's good for you. So you shouldn't be challenging us because we already have done the science. We've already done the work. That's not how behavior change works for communities of color. All right. So you need to understand that the first rule is that the receiver of the message has the right to challenge the sender. The second rule is that they're going to challenge you with arguments. In the oral tradition, you're trying to get me to change my behavior, right? In De Clementi's model, it's cost benefits. In the oral tradition, it's argument, counter argument. So you have to understand my arguments. When I share with you my arguments around why I don't want to change my behavior, I'm giving you the cost of what it's going to do, the cost to me to change my behavior. In De Clementi's model, it's benefit. So in oral tradition, it's counter argument. You have to give me the counter argument, which is the benefit for why I should change my behavior. I have to do this cost benefit analysis. So then I can go from pre-contemplation to contemplation, preparation, and we go through all those stages. So in our campaigns, we first identify where the primary target audience is in their behavior point. Remember I talked about point A to point B. We need to understand if most of them are in pre-contemplation. A lot of campaigns, they're in contemplation. So it's how do you speak to where they're at in the behavior change process. So I want you to understand, though, is that the second rule is you have the community is going to challenge, one, they're going to challenge you, and then they're going to challenge you with arguments. And then the key part is, do you have what we call persuasive counter arguments? That's the benefits. So I want to do real quickly, you guys, this is some of our old work around marijuana. So I've been doing, obviously I haven't been doing it recently, but because there's obviously been a significant turn in our approach to marijuana prevention, but I still think it's important for us to understand that it is a gateway drug to some of the harder stuff for teens. So we have to keep that in mind. But what I want us to do real quick is go through this oral tradition process with argument, counter argument. So you guys are going to be the senders of the message. So remember, first rule, we're not going to be able to do this here, but I have the right to challenge you. So I get to challenge you with my arguments, and then I want to see what kind of counter arguments you have. So here we go. So I know Dave is going to put these in the chat. So the first one is, well, you know, in terms of smoking marijuana, it's cool. I mean, you know, rappers do it. Bob Marley did it. Bill Clinton did it. I mean, it's a cool thing to do. I mean, what's wrong with smoking marijuana? So again, understanding that that's an argument that young people give us. And by the way, I've done this argument with young people a number of times. And just, I'm not being facetious. You sometimes walk away like, that's a good point. And so you have to understand that the community has their own arguments on why they're engaging in those behaviors. So let's go. We got it's cool. Hopefully you guys entered some counter arguments. How do you counter that it's cool if a young person gives you that? Next one is it's not addictive.
So Ivan,
Yeah.
as you go into the next one, before you go to the next one, so you're asking us to put in the chat a counter argument to it's cool, correct?
Perfect.
Right. So
Yes.
for everybody that can participate now, please do so.
All right. So do that now. The counter argument to it's cool. And then the next one we want to do is, as they say, well, and it's not addictive. I've never seen anyone overdose on marijuana use. I've seen them, you know, basically fall asleep or have the munchies, but I've never seen anyone, it's not addictive. We'll get back to that in a minute because it actually is addictive. But again, a lot of young people don't realize that. Then here's a big one, makes me creative. Let's enter that one in, makes me creative. If you know, hey, I'm trying to write some lyrics or I'm trying to do whatever my talent is. And I find that, you know, being high makes me more creative in doing that. Here's number 4. Go ahead, Dave. Number 4 is it's an escape. You know, look at where I live. You know, I mean, I'm trying to cope the best way I can. This is how I escape my reality, right? And then there's the group now, obviously, these are old arguments prior to many places it becoming legal. It should be legalized anyway, right? Should have been legalized a long time ago. Now, number 6 is a good one because young people tell, what are you talking about? My family, my friends, you know, people I look up to all do it. They have their reasons for doing it. So if this is a behavior that's modeled, what's the counter argument, you guys? And then finally, now you see a whole industry being created around pro-marijuana use, that it's healthy and it's natural. Well, young people have been saying that for a long time. It's healthy. So you guys think about but again, what I want you to understand is in the oral tradition, first and foremost, you have to be open to being challenged. And people don't like this. I'll tell you just a real quick story on being challenged. So we do a lot of work in education. So I do this workshop for school teachers around the country as part of their continuing education. Teachers will tell me all the time, well, you know what? Jimmy was disruptive and he would ask me questions. He'd raise his hand and I would shut him down, or I'd send him to the principal's office and I would say to them, that was Jimmy, who's an oral-based culture, trying to challenge you as the teacher to see if you were open to a relationship. And then she would say, well, as part of that discussion, she says, well, you know, he's quiet and he's good now. And I said, now you lost him because now he's not willing to engage you. You've lost someone who subscribes to the oral tradition, who was just wanting to know, are you open to being challenged so that he or she could get the content of your message? That's where we miss a lot. One of the things I want you to understand about oral culture, it's actually a compliment if the community challenges you. They don't have to give you their spirit. It's actually a compliment because in a real way, they're saying, are you open to a working relationship as we define it? Not as you define it, but as we define it, because we need to know if you want us to consider behavior change, you got to be open to being challenged with the arguments that we're going to give you so that you can give us your persuasive counter argument. So I want you guys to really understand that you need to understand the oral tradition. I'll just tell you real quick. So I've been doing this for a lot of time. So this is on the training portal. People go, well, Mr. Juzang, where is the literature review on the oral tradition? So there is the literature review for folks who need it to understand that there's clear science on the oral tradition. If you go to any major school of communications in the country, you'll see that they have a department of rhetoric, persuasive communications, all that deals with the oral tradition. Carlton and I were talking before about his work in Alaska. Native Americans, the oral tradition. Native Americans have been passing down their stories for generations and even planning, as you guys know, 7 generations ahead. So understand that the oral tradition lives today, even in our whole digital world. It's still important to understand. And we'll talk about even how you interact with this audience, even if you're using media. So there we are there. Now, real quick, if you can add 2 more, Dave, for me. What happens if you're successful on all of these arguments in terms of counter, and then at the end of the day, young person says, well, I don't care. I just don't care anymore. What's your counter there? Okay, good. But I don't care. And so people always really don't know how to deal with that counter. So if you can, any thoughts on how do you counter the fact that at the end of the day, young people are still going to say, I don't care. The other thing that young people always tell me is, oh, I'm in control. That's another one. Oh, I'm in control of it. And I always say, well, okay, you're in control. Well, if you're in control of your marijuana use, just stop for a week, just 1 week. And because you're in control, you are in control. And they all come back like, oh my goodness, I am not as in control as I thought I was. So this is what these are ways that we need to engage community. So now let me start shifting to why this is important, understanding these 2 things, the oral tradition versus litter-based culture and worldview. So I've been working, with ONDCP, CSAP, Robert Johnson Foundation, Partnership for Drug-Free America. And I have to let you guys know that if you look at what's been happening on the right, the war on drugs has been going since 1971. The opioid crisis, we're probably 10 years really into this now, where we finally started dealing with this, right? So if you understand how we've approached the war on drugs versus opioid crisis, you'll get a good sense of what I mean by the social determinants of health disparities. So if you look at the war on drugs, again, who did that target, you guys? That first row. The war on drugs targeted primarily Black, brown, inner city, and poor people in rural areas. Who does the opioid crisis primarily target? White, rural, suburban, primarily focusing on the opioid epidemic within primarily the white community is really where it started. Look at how the war on drugs was even just described. Again, this is messaging, you guys. This is framing. This is important to understand. So how do we describe it? Well, you were on heroin, you were on crack, you just did dope. We don't even use that language for the opioid crisis. We go, oh, it's opioids, right? Heroin forever, now it's opioids, prescription pills. So again, think about what we're saying to the audience just on how we're framing this. How is it distributed and how do we frame that? Well, you're a drug dealer. You're from a drug cartel if you were dealing with the war on drugs. Look at the opioid crisis. It was pharma distributed, right? Again, understanding that. For Black people, you were an addict, you were a crackhead, you were a junkie. I mean, just straight up deficit language. Oh, you have a substance use disorder. This is a disease. Think about the framing, what that would mean to you if for the last 50 years on the war on drugs, if we had been framing it the way we're framing it on the left side. Just think of the progress we would have made. I can tell you this right now, we've spent tens of trillions of dollars on the war on drugs. What if those resources would have been used in a prevention fashion? So again, look at the institution that was driving the behavior. So in the war on drugs, it came out of criminal justice. Look at the opioid crisis that comes out of our public health and mental health and substance abuse, where it should be coming, by the way. So this isn't saying what we're doing on the opioid crisis is wrong. What we're doing on the opioid crisis is right. We just should have been doing it the whole time. So in Philadelphia, we have safe injection sites. What do we have on the, you're just a crack house. You're in a crack house. And again, final thing on framing, it's harm reduction. We want to help, we want to save. We should have been helping and saving and doing harm reduction instead of demonizing, locking up, incarcerating. And I know Louisiana understands this because of the incarceration rate there. So what I'm saying, you guys, is it's important to understand this framing, because framing leads to perceptions, stereotypes, beliefs. Those lead to practices, policies, and laws. You guys have the responsibility to start reframing what we're doing in communities of color more on the left side, and you need to advocate for that it's important for how we frame these messages. So now we're going to get into actually how we do this. But I want to summarize this part by saying, this is why you need what we call a community-centered framework, sender, message, channel, receiver, and this is a community-centered framework. When I say this is all about who your community is first, and then how do you start reaching them. So what I just want to end with this is saying, got to understand environmental influences, social determinants of health, they might change, but if they change for the positive, not immediately. If they change for the negative, it tends to happen faster. But what I can tell you is stress and trauma are going to continue to be constants. Digital technologies, you guys are here for media and literacy, but I'm just letting you know, digital technologies will come and go. And so we need to understand that we have to focus on how we inform laws, social and public health priorities. And so we want to evolve that. So again, sender, message, channel, receiver in reverse. So here we go, you guys. So we're going to go now to the channel. So we did the receiver, right? We spent I always do this. And actually in my actual project, people say, when are we going to get to the campaign? We got to spend some time with the receiver. We have to understand how they view the world and how they communicate. So even in my workshops, I spend the most time here, and we'll go through these other letters a little bit quicker. So here's what we do in terms of communications, media and literacy, and particularly around that stuff. I just want y'all to understand that what we do with all of our channels is you're looking for a channel that's going to give you an opportunity to have that dialogue. Remember, we just talked about in the argument, counter argument. I use media and communications to figure out how I can have that argument, counter argument dialogue, how I can be challenged by the community. That's what you're trying to go to. So we can tell you, we track all this. I can give you all the research on how much media these communities consume, how they consume digital, social media. We track all this because we need to understand it, and we do use it as a tool. We understand and place a lot of media in Louisiana using social media. So I'm not saying we don't use it, but we need to understand it. So these are the kind of channels that we see people use: print materials. And then I want you to focus on the last two. You sit there and say, well, that's a channel? Yes, community outreach and mobilization is a channel, right? Peer educators is a channel. Peer educators are a channel. So we want to understand that, again, if you're speaking to an oral-based culture, the goal is to create a behavior change dialogue. And if I work with the community and peer educators, that's going to give me the most opportunities to engage the community in that dialogue. So we're going to talk about those two as well. So I want you to understand now, here's the part under channel. Remember I said, just in terms of your notes, this is just something we developed for APHA last year or 2 years ago before before the pandemic. And what I want you to understand is that this is what people think. I can't tell you guys how many clients come to me and say, well, what does the media look like? That's all they want to know. And, what I always say is it's just evolved since the early 90s. When I first started Media Productions, all the clients want to know is, what's the brochure going to look like? Think about that. You guys think about that. What's the brochure going to look like? That's all they wanted to know. Then it moved to, okay, what's the website going to look like? This was all before social media. And now people go, well, what's the social media going to look like? What I want you to understand is that that's not going to help you really engage the communities, right, in a way that you need to. It's more of a literate-based approach for an oral-based culture. So I want you to understand, and we're going to talk about why you want to prioritize community outreach, community engagement. And I'm going to show you how you can do it. All right. So here's the part I need you to write under channel, just 3 things. What I want you to understand, when you're looking at channels and you're thinking about channels, you need to put all your channels in these 3 categories, just so you know how to position them for communities that have high health disparities. What I want you to do is just under that, see that column most. What I need you to understand is what communities do, and this is why people want to use media so much, because it is true. These communities spend the most of their time using media. So what I want you to write there is consume. It's a different word than I want you to put the word consume there. So yes, high digital media consumption, they consume media, lots of hours on screen time. But we're talking about behavior change, you guys. I'm not talking about advertising. I'm not talking about consumer marketing. I'm talking about behavior change. So understand that communities do consume a lot, and that's good for advertising. It may not be the best for behavior change. That's what I want you to understand. So when people say, let's run and develop media, understand it. I develop media. I'm an award-winning producer. I understand media, and we'll talk about how to develop good media, but I'm just trying to get you to understand in terms of behavior change. Now, with peers, write the word influence. Peers have the most influence in terms of behavior change. Again, remember, they consume media, but peers have the most influence around behavior change. And then finally, you guys, as prevention leaders working with the community, have the most power. I always put the word unrealized is because people don't realize the power that they have to mobilize communities. So it's the most powerful form of behavior change communications. But people don't use it because it's unrealized, this power that they have. So just right here under channels, we know that they consume, the low-income communities consume huge amounts of media. Peers have the most influence, but we have the most power. And I always tell folks, anytime you blame it on rap music and that stuff, guess what you're doing? You're giving up your power. You're saying that those things can beat me, and they can't, because you haven't leveraged your power that you can have in terms of behavior change. It's ironic. I can't go into this, but what you guys, it's not this workshop. But this is so important to understand that all of our corporate clients, what they're trying to do now is they're trying to get closer to the community. They realize their advertising isn't going to get them that next marginal sale. What they're realizing is I got to get closer to the community. So you're now seeing, look at this, you guys, you're seeing corporate America partner with the big nonprofits and NGOs because they help them get closer to that audience that they're trying to sell to. So I just want you to understand this is important. But right now, in terms of behavior change, this is what's happening. Okay, got to keep moving, you guys. Real quick on media. What we try to do overwhelmingly, you guys, is we do use both. So you'll hear me use this term, online means media, offline means community. That's really what we're trying to do. We're trying to build a trusting relationship that can have real dialogue. Yes, we use online and media. Why? Because it gets us scale. It helps us get to those communities in terms of reach, but the humanology is what gets us behavior change. So we say, technology for reach and scale, humanology for dialogue and behavior change, because you got to have the dialogue to get the behavior change. So that's what I want you to understand. So let me give you a quick example. This is directly from what we're doing in Louisiana with the Quit line. So online experiences, we get them to sign up and get a quit kit. Quit kit. Say that a number of times, right? We get them to be able to have access to community resources. We share with them stories, the narrative, oral tradition. This is where you use media. We tell stories and tips from quitters to quitters, right? We have videos on resiliency and other ways to cope with tobacco. We provide access to digital peer support services, right? So, and then beyond just the disparity of tobacco misuse, we try to connect them to other services. So this is where you can use an online experience in terms of media, but what are we really trying to do? We're trying to drive them offline to the community-based program. So what we have set up in Louisiana is the tobacco cessation classes in that parish, how we also can lead them to stress management and mental health services, actual in-person male support groups, connecting them to FQHCs and rural health centers so that they can get dental, other behavioral health services, right? This is what you want to do, you guys. You go back and forth. So when we have them in the community, we say, okay, but make sure you're following us online. So remember, online drives them offline, offline drives them online. You guys get it? So this is how you want to use your channels as a way to create the relationship with the community, and they work together. So that's an example of how we're doing it. So let me just take you real quickly, and Carlton, I know we're running against the time. This is a whole workshop in itself. So how do you do community engagement? So I got to go through this fast, you guys, but I do want you to understand that this is where I spend most of my time. So people go, well, you're an award-winning media company. Yeah, I've won every award you can win. And people say, well, why do you do so much community engagement? Because I'm trying to get to the behavior change. So this is all about community engagement is the channel. So your community-based organizations, your community leaders are the channel you want to use to get these messages into the community. Why? It addresses and engages skeptical residents who have low levels of trust. It addresses risky behavior by creating opportunities to have dialogue. The messages get reinforced by people that they know and trust because you're working with community-based organizations. And finally, through this dialogue and discussion, arguments get countered, awareness increases, attitudes and norms change. This is why community engagement is critical. And so I just want to show you real quick about how we're doing this. I'm going to kind of jump ahead. Well, actually, I'm going to come back to this. I want to jump ahead to the messaging part so we can come back and spend just a few minutes, hopefully, Carlton, back on the community engagement part. But now people say, okay, well, what's the message I should put in that channel? Remember, we just did receiver, we're on channel, now we're message. All I say is that at the end of the day, we want communities to make informed choices. That's what I say all the time. You know, you can't tell someone what to do. You can really give them the information to make the best decisions based on understanding all the choices and then understanding the consequences for those choices. So this is what we're doing. This is again, I was just showing you how we framed it for the tobacco, but this is the same process Carlton and I have used for our opioid work in Ohio. Same process. How do you frame it? So all I want you to understand is that when we look at messaging, we understand that people cope negatively with a lot of stress and trauma, but you also have to know that they can cope positively. In the lowest income communities, you guys, we see this happening. So this is what we track. We track negative coping, which is misusing alcohol, tobacco, addiction to sugars, resolving conflict. We see all of this. This is what the media shows us. But we also see what we see on the right. We see a lot of folks understanding how to take care of themselves in the moment. And these are what I call the protective factor skills. This is what I try to promote now. I try to promote these 5 topics: self-care in a crisis. How do you practice wellness as an alternate to coping? Thriving skills. This is the resiliency work, healing and resiliency work. Being connected to other caring adults in your community. And then, as you guys know, the importance of being linked to trauma-informed services. So this is the messaging. I just want you guys to know the science on this is clear, that if people have protective factor, which is what I say is primary prevention, you'll see folks with less mental illness disorders and some with no, faster recovery and healing from trauma. And then still a lot of folks will need the best modern and ancient treatments. So we track all this. And so Me Productions has 7 thriving skills that we've seen in the lowest income communities people do that enables them to thrive versus just survive. And that's, they know how to take care of themselves. They have a sense of self, improvisation, higher power. You see that a lot in Louisiana, not necessarily just spiritual or religious, but just knowing that there's something bigger in the universe. Having a plan is a big one. We do that a lot with our quit line stuff. People who have a plan, you guys, deal much better with stress and trauma than folks who don't have a plan because they catastrophize. Connectedness to others, I mentioned that. And then navigating, people get mad when I really put what I want to say here, which is navigating systemic racism. You got to teach folks how to navigate. It's not going to change immediately, but we have to give them advocacy and navigating skills to be able to do that. Where is this at? There's clear science on this, you guys. So I've been working with folks doing this, including Dr. David Satcher. What I want you to understand is that risk factors have been around for a long time. Again, primary prevention. David Satcher said in 2001, for both the youth violence report and the youth suicide prevention reports, risk factors are not predictive factors because of protective factors. You guys, this is a SAMHSA funded conversation. You can go to SAMHSA's website right now and find the protective factors across the life cycle. So there's clear science on this. My question is, why aren't we doing more primary prevention? I know you guys obviously know that because you're prevention leaders, but this is the conversation we got to start having across the board, not only just to deal with substance use, but then the number of health disparities that our communities are faced with. This is on our website, so you can have detail on protective factors. I can't go through this now, but the notion is, again, is that we want to give folks those primary prevention protective factor skills. And last point on this one in terms of messaging, and again, we've done a suicide prevention campaign using protective factors in Ohio. We're doing violence prevention using protective factors in Philadelphia. And I'm hoping to work with Carlton on looking at the same model around substance misuse, right? How can we have this humanology technology approach to presenting protective factors? Last thing I just want to mention on this, you guys, is coming back to the community engagement part, and then I'll wrap up. So back to that real quick. We prioritize community engagement as a company because it's both a channel as a way to get the message, and then it's the sender. Here's what I want y'all to understand. At the end of the day, you guys, what you're trying to do, think about it. You're trying to have the best relationship with that community. So you want to have the best relationship, therefore, with community leaders from that community. And that's going to help you have the best relationship with that group of folks. That's going to have you get you to have the best relationship with the community. It's all about how do you get to the relationship. Remember, relationship gets you behavior change because it's going to get you dialogue. And so you have to start understanding that, yeah, we're going to do communications. We're going to do media. We're going to do social media. We're going to have a great website. We're going to do great PSAs. By the way, if you look at all of our PSAs, which I don't always like doing, but when I do them, I embed both the argument and counter argument. If you look at bad PSAs, they only give a counter argument, but they don't give the argument, which then tells that community, you're speaking to my arguments, you're speaking to my worldview. So we got to do community engagement. I talked about that. On this point, real quick, I just want you to understand is when you do community engagement, you have to have a win-win approach. You can't just focus on your win with the community. You also have to focus on the community's win. So yeah, your win is going to be able to use this as a channel to put information into the community and take information out. The community's win is that they're going to have better access, not only to healthcare or treatment services, but in a respectful, quality way. That's what you're trying to get to. That's the community. The community wants to access services, but they want to be treated with respect. Respect is the number one thing that they want from folks who want to engage them. So real quick, this is what we call the multiplier effect. So think about this, guy. If you're within Louisiana, you put yourself in the U slot. If you start working with community-based organizations and community leaders, they have access to their constituents and their constituents have access to their communities. This is how you get a very powerful channel in place because you're mobilizing folks who are willing to take the message out for you. Real quick on this, Carlton, I do media buys. What happens when the radio buy is over? The radio ads stop. If I do this, it goes on forever. So you have to understand that when you have, remember I said cost effective. The reason why it's cost effective is because now you can have an ongoing relationship with the community. Now, in our next workshop, hopefully we'll teach you how to do this, but there's keys to effective communications, community mobilization. As I said, I just don't walk into the community. I build credibility, trust, that gets you access. I involve the community. By involving the community, I get value. It's sealed by having a spirit of reciprocity, and then I have a working relationship. So this is a workshop in and of itself. So I don't want you to think that, okay, we're just going to start it. You have to understand how to go into communities. Even if you're from that community or you think you are, you got to go through the gatekeepers. So, and again, this is, if you do community engagement, this is the SAMHSA model. It helps you assess needs because you're taking information out. It helps you build capacity. It helps you have better plans. It helps you enable to implement. Carlton said at the beginning, how do we get to widespread adoption? And then you can evaluate because you're actually having a relationship with the community to evaluate what you're working with. Here are the mobilization tactics. We don't have time to go through it now, but I just want to show you guys a quick case study. This is the work that I've been doing in Louisiana for the last few years. I have organizations throughout the state. And I have community-based organizations, barbershop, because I've been doing community organization, community mobilization, re-entry programs, job placement, training. I have all of these kind of organizations. And so think about when I go in, again, when I go into work with Bureau of Family Health or LPHI, I go through the gatekeepers and I can take information out. I can put information in. It's a channel, and it's not only just a channel, it's the best sender of the message. Here's our work in New Orleans. So we have organizations throughout New Orleans that, again, when I start doing anything in New Orleans, I don't sit there and go, oh, I know what I'm talking about. I go through the community and understand what's their worldview on that current issue that I'm trying to deal with. So again, this is what we're doing in terms of I just want to summarize. You want to use a mix of channels, digital, online, but the key thing is humanology. Humanology is going to get you the impact. When people just say technology, that should be a red flag for you. And then you should say to them, well, where's your humanology? And then you got them. Then you see the argument, counter argument. They're going to go, I don't have a counter for that. So understand that, you guys. Again, last thing on community engagement, it's hard work, but the benefits are great. They're extensive because you're able to go in and constantly have a relationship, particularly around prevention. Here's my last two slides. This is the work that I'm trying to do in my last 5 years. I focus on primary prevention by putting protective factors in communities because it addresses multiple health disparities. I try to transfer my skills in terms of community engagement like we did today and hopefully in the future to prevention coalitions. This is Carlton and I's work going forward. How do we help coalitions have the skills to effectively mobilize their leaders? And then finally, beyond that, there's always a need for prevention, but we always know that folks do need treatment, but you got to get them to treatment where they're treated right. If they're not treated right, you're going to get negative word of mouth. If they're treated right, you get the positive word of mouth. Again, we want to focus on protective factors to help communities balance the risk factors. I just want to share last thing with you guys on our website. We have a number of resources. So we provide social media 101 because people want to know how to do technology. So we can do that with Carlton. We do community engagement 101 for coalitions. We can share our opioid research. We have expert interviews. We have all kind of stuff, particularly around alcohol, tobacco, and other drugs. So we're more than welcome to share because again, we want to really deal with these health disparities, underage drinking, tobacco, retailer education. On our website is how we tackle the opioid epidemic from the ground up, community engagement, right? There's some other resources on there for you guys. This is direct research from Louisiana, particularly around our work with Black men there. How do you create safe spaces to engage African-American men? This was all just based on the state of Louisiana. So we have that information because again, what we've been told is that programs create better safe place for women, but they don't do nearly a good job for men, which is why men don't access these programs. Carlton and I have primary prevention messages around a variety of issues. And then we've also had the opportunity to develop we've developed campaigns for folks, particularly around opioid prevention. So how to mobilize folks, how to address peer pressure, how to prevent overdose deaths with naloxone. Now, this all talks to low-income communities of color. This was the work we did specifically in Ohio because Ohio had some very specific Good Samaritan laws. I don't know what they are for Louisiana, but again, people don't call 911, right? Because how they've been treated. They don't trust the system. So you have to educate communities not to be afraid to call 911 and then know your rights to save a life. Really appreciate it, you guys. Can't thank you enough. Again, all of this stuff is on metrainingportal.com, Keynote. Sorry for running through that. Obviously, it's a lot of information, and I know you feel like you've been, fire hosed, but hopefully I can bring a light to some of that.
So let me just say, I don't know how many words you've gotten, but you're going to get another one from me for the fastest delivery of that presentation that I've seen to date. But extraordinary. Thank you so very, very much. If you can stop sharing your screen.
Yep, did it.
We can bring everybody up. What I want to do really quickly, everybody, is if you wouldn't mind, folks, can we show Ivan some appreciation, please, for the wonderful content that he provided? If you can feel like you can come on, wow. do the little clap thing and the hand thing and all the gestures. It was important for us to include as a part of this series a specific conversation about how we communicate. And many of the tools that Ivan shared with us are things that I believe our prevention world needs to begin to master and take into consideration as we are applying the other tools that we have been given and have been working with. And so I want to thank you all for the invitation. I want to thank Ivan specifically for bringing that depth of information knowledge. I want to ask anyone, we have some wonderful comments that are in the chat. I want to ask anyone, if you have a question, I think we have time for maybe one or two. If you have a question, if you haven't put it in the chat, if you want to raise your hand, we can unmute you and you can share that question. If you have a question, please do so. I'd hate for this to go through without the opportunity of being able to address any question that you might have regarding this. Leslie, thank you so much for the opportunity. Again, Felicia and Amber, thank you so much for the opportunity to be able to do this. Any thoughts, any questions that anyone wants to share, provide just a moment or two? Ivan, as they're gathering their thoughts, I want to share with you a couple of key pieces. One, I thought it was really interesting, and I was hoping you might be able to share just a tad bit more on when you said the sender, message, channel, receiver, but from the messaging composition aspect, looking at choices, decisions, consequences, and I can't remember the last one.
We're taking responsibility for that.
Responsibilities, right. Could you just do just a little tad on that? And then Paula, I'm going to turn it over to you for closing comments. Dave is, if you can put in the chat the evaluation link. Folks, the evaluation is going to be open for us. Please just go there. It's going to take 5 minutes for you to just go through that, do the evaluation, and we'll be able to capture that information for our report. And we will be able to provide a PDF of the presentation along with a video link for you all at a later point. So, Ivan, please.
So real quick, think about it this way, you guys. What you're trying to do is help the community make informed choices. If you try to tell them what the choice is, then you're going to lose them, because then you're preaching, right? You're telling them what to do. But if you say, here are your choices, we want you to make an informed choice. So right now we're doing a big COVID project in Philadelphia, in Pittsburgh, particularly around vaccine hesitancy. So we're not saying you have to take the vaccine. We're giving them all the information in terms of cost benefits to doing that. But the important reason, the reason why that's important is because you ultimately want to be able to have that relationship. And this is what's going to give you that opportunity to have the relationship. So that's the key reason why we're doing it. We want communities to be informed health consumers. And the more you start doing this, it teaches them the process on how to make better, healthy choices, because it's all about me not telling you what to do. It's helping you make an informed choice. And then that's going to give you the opportunity to have the next conversation and the next conversation. Remember, the community's only going to go to that. If you think about when you were a kid, right? Carlton, your grandma would tell you this story, and you'd be like, well, why is she talking to me about that? I'm 8 years old. I'm not even dealing with that issue. And then remember when you're in that situation 4 or 5 years later, you're sitting there going, that's what my grandmother told me. Planting the seeds. When you do this process, you guys, you're not going to get the behavior change immediately. You're planting the seeds so that they can use that information later on. Just the same way your grandmother from the oral tradition was planting seeds with you around the behavior she wanted you to engage in, right, as a young person. So good question.
Perfect. And thank you so much. It is so vitally important, because if we're indeed going to have population level impact, we have to consider these kind of methodologies that will enhance our ability to bring the broader population into the conversation. And so with that, as I shared before, Dave, please put in the chat, and I think you already have the evaluation link. Please do so. That's very important for the reports that we're providing to the state. I want to encourage everyone, please, please, please don't forget our next time we're going to be together, May 28th, and we'll be able to take this conversation even further. We're going to have a conversation about moving beyond COVID and how we might think about the real role for us as preventionists and in treatment and recovery during this time of national crisis. And we'll have that conversation with you all on the 28th. And we're living in some very urgent times. And so with that, I thank you all for your leadership and who you all are choosing to be. I turn this now over to Paula for their final comments and for closing us out. Thank you all. God bless. Thank you, Dave, for your great support.
Hey, Paula. Paula?
Yes, ma'am.
Could I say something real quick?
Oh, please, absolutely. I was looking for your hand.
So, well, I just wanted to say, I mean, like, such a big thanks to LCPR, Carlton, the colleagues and friends that you have brought to our state. Thank you so much, Ivan, the information today. I mean, the information that Carlton, you've been able to provide over these last few trainings, it's not that we haven't heard the information before, but the way that it's being presented and the application and how it's like, and I've been in prevention for a while, but, you know, really kind of connecting the dots that have kind of, I don't know, I've just been blown away. So thank you, LCPR, Carlton. Dave, you're like the coolest host, Zoom host, and I have participated in too many Zooms. I mean, what a great job that you guys do. So I just wanted to thank you, because you guys are You guys are rocking it. I'm so excited that our coalitions and our local governing entities and our prevention coordinators, and trust me, we are pushing, we are encouraging people to log on, to get on these trainings. And so I wanted to take a moment to just thank you guys for that. So Miss Paula.
I'm so happy that you talk, because it's amazing to have the partnership with OBH and the leadership from you, Leslie and Felicia. And I really appreciate all the guidance that you guys give it to me. And it makes me feel like I have you guys in the back. It makes me do my job like happier and better. I want to thank everybody that came to the call today. And I want to thank Carlton, Ivan, and Dave. Look, we are getting at the end of this series, and I'm already missing you guys. So I need to start saying like, oh my God, how we bring them back together. I enjoy my Fridays with you guys. Dave already put it on the chat room, the LCPR website. I encourage you guys to visit the website, check the calendar, check the trainings. We are on the prevention month. We have several information on the website about the prevention month. I hope your coalitions are doing the activities that SAMHSA recommend for the prevention month. If you guys need any support, any resources, please let me know. And check your emails for the CEUs. Let me know if you have any questions. LCPR is here for you guys. Happy Friday and be safe out there. Thank you, everyone.
Thank you, everybody. Thank you very much, Leslie, for your
Be
kind
safe.
words. God bless.
Oh, you're welcome. And for those mothers out there,
Oh, yes.
Yeah!
happy
Yes.
Mother's Day.
Thank you.
Happy Mother's Day.
Happy Mother's Day.
Yeah. so-
Yes, indeed. Absolutely.
Bye.
Take
Love
care,
you
everybody.
guys.
Have a great and blessed weekend.
You
Thank
too.
you.
Bye-bye.